Part 2, as I'm hacking. Part 2 of the pelvis and thigh trail guide. Pelvis. Because I decided I don't care if they see me or not.
My husband asked if anybody could watch these videos, and I said, yeah.
Is he going to?
No, but I did tell a student that they could.
Go learn. Let's learn about the gluteals. These are the booty. These are the big back muscles.
Carly got to feel mine a little bit. I did.
Gluteus maximus. This is the most superficial. Right? So you got your other glute muscles, and then this guy is just like the blanket for the butt. So all the fibers will extend your hip. So it's going to bring your hip back. All the fibers will laterally rotate, and all the fibers will abduct. The best explanation I have for this is your dog taking a leak on a fire hydrant. All right, so that is your glute max muscles. All right, so that movement would really get the glutes. The lower fibers of the glutes help to adduct. So that guy is kind of bringing it back. All right. The origin. So this picture has the origin of all, the max, the med, and the minimus. So it's going to kind of line the hip here. So it's lining the coccyx and the edge of your sacrum. And then also it kind of goes up into the posterior iliac crest and some other ligaments, the sacroiliac ligaments and the sacrotuberous. So see how here it kind of traces all the way from iliac crest down the sacrum, right? And then there's some ligaments kind of thrown in there. And that runs down as like a nice, we'll call it a teardrop shape. And it connects onto the iliotibial band and also the gluteal tuberosity, the lower fibers. So you'll see this picture here. Let me zoom in. So branches off into two. These lower fibers here is what adducts the leg back to central. And these fibers here run into the iliotibial band. So IT band. Just like the TFL muscle. So that's your glute maximus. Sounds like a transformer. A transformer that turns into a dog so it can take a leak on a fire hydrant. You're welcome. All right, gluteus medius. I call this the top of the heart. The heart shape. As in your iliac crest as it comes together with the sacrum in the middle, right? That's the heart. So this muscle is actually super important to work on to address low back pain. This tiny little sucker. So all the fibers, again, like a dog, is going to abduct the hip. Then you have your anterior fibers. So that's kind of, more anteriorly and posterior fibers. So I'm going to zoom here so you can see anterior here and the posterior fibers of the medius. All right, so anterior fibers will help flex the hip. It's in the front of the leg, so that's the action it's doing. And it'll also kind of help to medially rotate a little bit, all right? So glute med is through this section here. So these fibers will help to pull this way. Does that make sense? Okay. Now, your back fibers, your posterior fibers, are going to do the opposite of the front. So instead of, helping to flex, it's going to pull you back into extension. Let me go this way. Fibers here. Pull you into flexion, extension, right? This is hard to hold.
People on the internet, all that clapping.
Hey, baby. That's the FEMA. It also will laterally rotate. Okay, so it's over here, and it's also going to pull on this laterally. So laterally and posteriorly. It is probably super annoying. So, the origin. The gluteal surface of the ilium. I'm coughing a lot from eating that donut. Phlegm. It's a gluteal surface of the ilium between the posterior and the anterior gluteal lines. I can't even see any lines here. We're good. We good. It's basically this little section here. And it makes that noise. Insertion. The lateral aspect of the greater trochanter. So you have your greater trochanter here. All right, the lateral aspect would be, the side. Boop, 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 boop. Exact. I really should have my face on here.
Do you want another donut?
No, I don't. I've had a headache since 1:30 in the morning. So I figured maybe coffee and a sugar, because that totally is going to work. And 4 ibuprofen should kick it. We'll see. I had one yesterday, and it went away, and then it came back with a vengeance. So glute med, top of the heart. Now, if I want to strip away maximus and strip away medius, underneath all that is your minimus. So this is a glute minimus. This primarily will abduct, bring your leg out again. They all seem to be abductors, right? Medially rotate and flex the hip. So this guy originates on the gluteal surface of the ilium between the anterior and the inferior gluteal line. So here's this line here, and minimus is housed right in this chunky area here. It runs down and connects on the anterior, so the front part of the greater trochanter. And you'll see that here, how the tendon, you son of a gun, how the tendon kind of wraps around to the front a little bit. So gluteal line runs and wraps around the front, which is why it'll do the rotation. That makes no sense, but all right. Next. So we're done with the gluteals. Let's talk about the adductor, the inner thigh group a little bit more. There's going to be the magnus, the longus, the brevis. Remember, there's always a longus and a brevis if there is a longus, right? So here is the adductor magnus. Magnus, think magnum, think large and in charge, right? So, obviously, it's in the adductor group, so it's going to adduct the leg, right? It's on the medial side of the leg, so it also can help to medially rotate the hip a little bit. It also assists just a little bit in flexion. The posterior fibers, so the fibers more towards the back, are going to extend the hip. So you have some flexion a little in the front and extension. But mainly, as long as you remember that it's an adductor, we're good to go. If someone has issues with their legs, you're going to hit the entire thigh, front, back, side, 360 anyhow. Origin, the inferior ramus of the pelvis. So that's this little section here, right? And then it runs down, connects on the ramus of the ischium. The ischium is the bottom. I actually had a little, while I am not sleeping in bed, I try to think of things to help you guys learn better. I can't even remember it now. Wait. Okay. To help you remember that the ischium is the butt bone. So Tish sits on her ish. But there's a C in there. Does that make sense? So your ischium, I-C. Yeah, I-S-C. There you go. So that'll help you to, hopefully, you'll be doing your MBLEX. Tish sits on her ish. So the ischial tuberosity is the bottom part of that ischium. Okie dokie. Anywho, so it starts at the ischial tuberosity and the pubis, right? Runs down the leg, and it connects on the medial lip of the linea aspera. Remember that line I told you about? And the adductor tubercle. So there's this little guy here on the edge or the bottom of your femur called the adductor tubercle. I can't show you because we don't have our skeleton in here. So you had magnus, now we have longus. So there's also another muscle that's basically very similar to the adductor longus called the pectineus, but that is in a couple slides. So we're focusing on this longer muscle, the longus. It is an adductor, yes. It is a medial rotator, and it also helps flex the hip a little bit. So most of these are going to have similar actions. Again, I'll press that you just make sure you know it's an adductor, right? Starts at the pubic tubercle, and it runs down and connects on the medial lip, words, Bridget, of the linea aspera. I'm trying to see if you can actually see it here. Sort of. So there's lines on the back of the femur where it kind of runs back and connects on down the back of there. That one's the more medial line. Brevis. Adductor brevis. This tiny guy adducts, medially rotates and flexes, assists with the flexion. It starts at the ramus of the pubis, the inferior side, runs down, connects on the pectineal line and the medial lip of the aspera. Same again. The M lip of the linea aspera, right? You're like, shh. See why it is important sometimes if someone is having issues where you might need to medially rotate the leg to get to these. Now, you're not necessarily going to be working on the pubis, but you can get as close as comfortably possible to try to address some of those attachment points, or teach your client self-care on maybe holding attachment points at the, around the pubic area and doing some of the stretches that might activate lengthening these muscles. So they can kind of do that themselves so that we don't have to touch their privates, right? Pectineus. This is an adductor again, medial rotator, assists in flexing. So when you want to stretch this too, you can kind of stretch it the same way you would stretch the hip flexor. If I were to remember hang it off the table or from prone, I can lift the leg up off the table, which is a little harder on our bodies to do. Did anybody practice that yesterday?
I did it on myself this morning when I got it.
You're like, no one was brave.
I did it on Kiki.
Did you?
We both did it, yeah.
Which direction?
We hyper extended the hip.
Shay and I did all the stretches.
Like off the table?
We did off the table, and then on prone, like the leg under, like what you did.
You guys are pros for show.
We tried it.
Very good. Very proud.
Can never be partners.
You today were so loud.
I'm going to just duct tape everybody and blindfold you. That sounds weird. And then make you try to do a massage and see how you do.
Until I end up broken somebody.
We had to do a massage with the lights out in our class. Just the back. When we had markers and we had to circle trigger points. It was super cool. We were way off because we didn't know what we were doing yet. Anyhow, let's get back on track. Gracilis. This muscle runs the whole length of your inner thigh, straight from the pubic area to the leg, right? Or to the leg, to the tibia, basically. Okay, so action of gracilis. We are still in the adductor section. So adductor, medial rotator, Flexion. And then medial rotator with a fixed flexed knee. She starts at the inferior ramus of the pubis, right here. She runs down and attaches to the proximal and the medial shaft of the tibia. Runs down, crosses the knee, connects on the tibia down here, onto something called the pes anserinus tendon. Here's a cool picture of all the adductor attachments. Let me zoom and just see how, like, this pubis area. Oh God, there's a big ween on the screen. Let's cover that. I was zoomed on the head. My God, shocking to the system. Anyhow. Sorry, I'm immature. We have the pectineus, the adductor longus brevis, and the gracilis all in this section here. So if someone was to have any kind of inflammation or injury to these tendons, they might have radiating pain in their groin. So when someone says they have groin pain, ask a lot of questions. Ask them when it hurts, where it radiates, because you might be able to just hit these adductor muscles and kind of free up some of that pain. All right. All right, so origin, here's a picture of just the blacked out marks, but it's basically this over here. Here's the back of the sacra, or the back of the pelvis. And here is all those, like the pectineal lines, right? All those lines on the back. We good? We good there? Pelvis and thigh muscle group 3. We're getting to the good stuff now. Tensor fascia lata, which, remember, becomes IT band. Yeah, let's just go. Let's just dive right in. The TFL, if you don't want to say tensor fascia lata, and the iliotibial tract. So we're throwing those together because, remember, I'm going to zoom real good here. See this anterior muscle? It's kind of like side and anterior, lateral and anterior. The TFL and the glutes here, glute med, all run in. Oh, and your gluteal fascia all run in. And see how thick this band, this fibrous band is? Probably. I don't know, man. Do I look like a scientist? I'm Googling it. I know it's a tendon. Tendinous.
Everything comes together.
It is an aponeurosis, like the Gallia aponeurotica. She's too smart. She's going to start teaching. I'm learning so much. So all that runs down and becomes the iliotibial tract, or the iliotibial band, or the IT band, whatever you want to call it. So what does the TFL do? It flexes your hip. It is on the side, so it's going to medially rotate your hip. It's also on the side, so it's going to spread the leg apart from the body. Abduction. Now, if you want to try to stretch this muscle, you do the opposite of the actions, and it might put a little stretch on the IT band too. Because you can work this fibrous band, but remember, it's going to take a little while for it to get warmed up, and you're not going to have as easy of a time stretching it out as a muscle could. All right. Origin. Iliac crest, we're talking about the front side of it and the posterior part of your ASIS, anterior superior iliac spine. This guy. Me. I really should have my camera on for this. All right. It runs down again and runs and becomes the IT band. Got it?
Bridget.
No. Question.
And this is like,
Should I go
guess
back?
just in general. How have they figured out, or how do we know that it's the insertion point and that it's the origin? Like, how do you know which is which? Like, I mean, I know they're telling us.
Okay.
How did scientists figure out that this is where that muscle starts and here's where it ends?
Let's go back in time and ask them. No, I'm just kidding. How do they know?
But isn't it based on the action?
It is based on the action because the origin is the non-moving part,
Right.
Okay.
and the insertion the insertion tends to be the bone that's moving towards the non-moving
Okay.
part. So, in this instance, if I have a muscle that's stuck right here, and this is where it starts, we'll just pretend that it runs down and connects here.
Okay.
This is not moving at all. This is stabilizing on the top of the hip. When it contracts, everything is coming towards the part that's not moving.
Okay.
Where is it insertion?
I probably should have asked that.
Yeah.
I should have asked that question 11 weeks ago. Perfect.
It's all right. Maybe I didn't explain it well enough, but I briefed up on it very quickly. But yeah, that's what's happening, and that's how they've discovered the actions of things. Like a lot of sometimes it's opposite, because then you have some neck muscles where it actually originates on like a lower body part. But typically, yes, the origin is the non-moving part.
Okay. Thank you.
I don't know how they figured it out, but
Somebody is smarter than us.
they're like, let's cut this person open while they're alive and then tell them to move something. You never know. There's some messed up people, or maybe they tested things on animals, which makes me sad. Yeah. They were probably just playing with like a dead human. They're like, what happens if I pull this little section and the knee goes up?
Or prior to anesthesia, gotcha. Cut open. We're gonna take a
Well,
look at
didn't
this
you
while
do
we're
the
here.
electric thing with the frogs in school? We did.
I don't
You
remember.
hit the
Yeah.
muscle with the electric and the leg will jerk or go.
We had, I don't know about your
We did that
frogs.
in college in exercise phys.
Was yours just brain dead? Your frog? Ours
Oh, now
still
that you say
had
that.
a beating heart.
I don't think mine did.
Yeah,
Somehow
our
we
teacher.
did the electrical impulse and it made the muscle
Yeah.
move.
Oh no, our teacher like jabbed like a needle in the back of its head,
No, we didn't do that.
and it was brain dead. But then we proceeded to its heart was beating, and I wouldn't touch it, dead or alive. Only with things. Yeah, I can't do that. I love animals. I can't do it. But this bad boy is a sartorius. He is called the Taylor muscle. Why, you say?
Yes, please, why?
I don't remember the origin.
Let's get the Google.
This muscle is this motion here. Knee up, crossover, like I don't know, the Taylor. I don't know why, I forget.
I'm looking.
Like Taylor, I don't know, maybe that's how they sat. Let's look it up.
I'm looking.
I remembered once. I just remember this, the Taylor muscle.
Because this action allows a person to sit cross-legged, a position traditionally used by tailors for sewing.
So that's how
Oh,
Taylor sat.
T-O-I.
Yeah, Taylor, like sailor with a T. So this is the cross leg position that actually is really bad for you. You're not supposed to sit like that. So when you think of the sartorius, it crosses from lateral part of the body to medial. So it allows you to, like you're cross-legging, just think, what's happening with the hip? It's flexion, right? It's laterally rotated a little bit. It's abducted a little bit. The knee is flexed. And then it also, if your knee is flexed, it could medially rotate a little bit. But if you can't remember the actions, this might be on the MBLEX, is the sartorius actions. They like to throw fun ones out like that. And you see why it's so important to get, when we're doing legs, to get as high as possible onto the hip, is because of all these attachments that are literally on the hip bone, okay? Origin, ASIS, another one of these guys. ASIS. It runs down diagonally to the medial portion of the leg onto your pes anserinus tendon. So ASIS crosses over, runs down to the tibia. Makes sense? That's why, since it crosses two joints, why it can do actions on both the hip and the knee joint. Now, this is like a thing you can try to remember. I don't remember this, but if you were to take your hand and put it on somebody's back of their leg with your thumb on the IT band side, the muscles in order where the tendons are would be, she gets some bad indigestion. If you're feeling so inclined. I'm going to be walking around today being like, she gets some bad indigestion. You got your hands in check. And you guys are going to be like, no, you're stupid. Let's talk about rotators. So we had the front of our hips. We had our glutes. We had our thighs and our, now we're andar. This is the andar. And now we're doing rotators. So you're going to have rotators that laterally rotate the femur, and you're going to have rotators that medially rotate. Man, I need water. The piriformis. This guy stinks. This guy sucks. This guy will give you sciatica. Yeah, you can get some good piriform stretches. They hurt. So the piriformis will laterally rotate your leg. It also will abduct the hip when the hip is in a flexion. So flexion, and it'll abduct, okay? Where does it start? The anterior surface of the sacrum. And you're like, what? What I mean by that is you have your greater trochanter here. You have your piriformis right here. It literally goes inside and connects on the inside of your sacrum. So when you are working on the sacrum or around your SI joint, you are not working on the attachment point. It is literally on the inside of the sacrum. Okay? Piriformis. All right, so the piriformis starts there anteriorly, runs kind of at a diagonal a little bit, and then smacks itself right on the greater trochanter. So this is where I'm going to stay. And then I'm going to get tight. What? No. I mean, you probably could. I don't know. I think it's a little too high up because the coccyx is way higher than the coccyx. I don't know, man. Look it up. Look it up. So, yes. Of course, Kiki would ask that question. Moving on to, oh yeah, rewind. It's anything that's, yep.
You lay on your belly.
So if it, yep.
And then here. And if you elevate your knee like an inch, put a blanket underneath of your knee, it shortens the two attachment points automatically.
So Kiki's always stretching her piriformis when she sleeps.
I can sleep, is that what you said? Sometimes, yeah, I just have one leg up.
Yeah, I sleep weird too. So, this muscle, when it gets overly tight, can push on the sciatic nerve. I'm going to go back a slide so you can see what I'm talking about. Sciatic nerve's like the width of your thumb. Running down. We're going to learn a little bit about sciatica today. Just a little bit. Okay, so here's your piriformis, right? And then it's kind of wedged. This sciatic nerve is wedged between a bunch of different muscles. So if the piriformis is getting tight, or any of these deep rotators, or if those have dysfunction, it could ideally add too much pressure on the sciatic nerve. Next thing you know, you're having sciatica symptoms, which would be burning, pain, numbness, even down to your foot. Some people just feel it at the gluteal fold. Some people will feel it down the leg a little bit. Some people will feel it all the way down. So it just depends on the severity.
You can put a tennis ball under your foot.
Yeah, you can put a tennis ball right in here and kind of loosen up. Those muscles just kind of lean against it. If you can't quite lay on it because of the weight of you, use a tennis ball in a wall, and you can kind of just apply pressure. It's kind of like acupressure to those muscles. Quadratus femoris. This might have actually been on my, is it a spell or is it a body part? So this guy is a lateral rotator of the hip still. It starts off on the lateral border of the ischial tuberosity. So ischial tuberosity, and here's that lateral border, yeah. Runs along, connects onto the humerus at the greater and lesser trochanters. So greater trochanter here, lesser trochanter here. It's kind of smack in the middle, right? Stay you. I'm so glad I bought a pelvis. Obturator internus. We have an internus and an externus. So this guy is also a little deep lateral rotator of the hip. It originates on a membrane called the obturator membrane, and then also on the lower inferior surface of that foramen, the obturator foramen. So this hole here houses your deep rotator obturator internus. So it starts here, and it, again, we get a little teardrop shape, shortens or, gets thinner, runs along and connects onto the greater trochanter, the medial side. So you had your internus. Let's talk about externus. So the difference between the two, let me see if I can go back and forth. All right. Does it have the same picture on both? Yeah. Does it? No. All right. So the internus, you'll see how it's kind of rimming that foramen. Rimming. This is the opposite, like the smaller section. Right? So this is more internal. This is more external. Here's a picture here. Just kind of showing you the two. See how this is kind of down in here in this section. This is kind of up in here. So the whole foramen, the obturator foramen is housing these obturator muscles from each direction. All right, origin, the rami of the pubis and the ischium and the obturator membrane. So it's housing that membrane, runs down and connects onto something called the trochanteric fossa of the femur, which is, here we go, this little guy here. Teeny. This little guy right in here. See how I can put my fingertip in here? That's where it connects. Deep in there. Cool, man. So many slides. Gemellus. We have a gemellus superior, inferior. Now, also, the chances of there being really involved questions on the MBLEX about the obturator or the gemellus is slim, but they might throw a question in there asking them about deep rotators, okay? They're probably not going to ask you about attachment points, but if they do, I'm sorry. Disclaimer, I'm sorry.
I'm looking at the book, hold on.
Do you have a MBLEC guide?
Yeah.
I bet Sartorius is in it.
It is, it's in there.
The talar muscle. Right, this lateral rotator starts off at the ischial spine. Ischium, all of it's that lower sits bone. And then it runs across and connects again on that medial surface of your greater trochanter. So it's a tiny, tiny little guy that just assists all the other lateral rotators that are housed in the section to kind of help bring your leg laterally. Superior and, wait for it, inferior. So right below that is your inferior, your gemellus inferior. Again, same exact like attachment points here. Ischial tuberosity runs across medial surface of the greater trochanter.
I'm not seeing either one of those, but I'll just say that it won't be there, right?
Right? This one's in there. Iliopsoas. So your iliopsoas is a combination of the psoas muscles and your iliacus muscle, which is going to fill this entire space inside of your hip. The entire space. It is an extremely hard muscle to palpate. Hurts like a son of a gun when you do palpate it, and when you actually palpate it, you're not palpating as many fibers as you'd like to because it's, deep in there. Also, the higher you get up, you now have your intestines in the way, so you're not really getting to the muscle, okay? So when we work on the iliopsoas, ideally, I'm having you guys work on the iliacus to try to address this. All right. So we have psoas major, bless you, and psoas minor. It doesn't even have minor on here. Let's just talk about major then. So this long hip flexor muscle can cause a lot of discomfort in people if it's tight. And a lot of people have super tight hip flexors anyhow because we sit way too much even here. So the main origin, or the main action would be flexion of the hip. It also says it may laterally rotate the hip. It may. Who knows? And that's when the origin is fixed. So the origin is that transverse process inside the hip, right? So where am I at? What am I talking about? I'm looking at the iliacus. The transverse process of the spine. So if this is in a fixed position, like we're not flexing down with the hip, we're flexing with the leg, right? This will help flex the hip and laterally rotate the hip. Now, when the insertion down here on the lesser trochanter is fixed, when we're holding down the leg, we'll say, or not moving the leg, it'll flex the trunk and the thigh, and it'll actually tilt your pelvis forward. So when this is tight, it can cause a little bit of a anteriorly tilted pelvis, which we're going over today, the tilts. Psoas starts, at the transverse process, runs down diagonally and is kind of, inferiorly and connects on that greater trochanter. Iliacus, here we go. So the iliacus fills the whole iliac fossa, the whole hip socket, we'll call it socket, hip space, not a socket. If the origin is fixed, if the hip is fixed, not moving, it'll flex the hip and it'll laterally rotate the hip. If the leg is fixed, it'll flex the trunk and thigh and, again, tilt your pelvis anteriorly. So, iliac fossa runs down, connects on that tiny little bone, the lesser trochanter. Apply your learning. I'm not going to, you guys can apply your learning at home. Look how far you've traveled. Whee! Okay, let's go over some ligaments. You guys can kind of read about the learning objectives here. Here's your blue cloud. So here's the inguinal triangle. Remember that this is an endangerment area. Not to mention, most people aren't going to want this area worked on. But this is an endangerment area that houses a lot of nerves, lymph nodes, arterial structures, and so on. So just like every joint in the body, all the joints of the pelvis are held together with lots and lots and lots of ligaments. So if you guys ever so care, feel free to look at the ligaments. Write them down in your trail guide book that I make you do anyhow. And get with it. So you'll just see all the ligaments. Ligaments can become dysfunctional or tear if there's an injury. Imagine like breaking your hip in multiple spots and then ligaments tearing. Ugh, sounds terrible. Let me see if I can find something here. Oh, we're actually going to learn about this. I have a little video. I believe I have a video to show you of the hip joints. All right, ligaments of the coccyx joint. There, that's what I was looking for. I knew it. So remember how the ball and socket joints have your labrums? So this is the acetabular. This is called the acetabulum, by the way, the socket.
So that's what you hear a lot of people tearing?
A labral tear. You also have labrums in your shoulder joints.
Okay. Yeah.
So what this does is it's like a ligament that allows for extra space of that joint. It's kind of like just kind of lining the outside there. So when that tears and the hip is moving, there's a lot of inflammation and pain with actions of the hip. Good stuff. I don't care about the ligaments much. We can talk about some other structures. Let me see what the next one is. Yeah, the sciatic nerve. Okay. My God. So we're going to zoom here on this triangle. It actually looks like a triangle, doesn't it? But this is why this is an endangerment point. We have our femoral nerve and artery. We have our femoral vein, a ligament that runs across called the inguinal ligament. We have a bunch of attachment points, right? Lymph nodes, great saphenous vein, and so on. So that's why we're not doing a lot of work here. If you're getting close to that point, if you feel a pulse, let go.
Let's go and try body work, and then you can like hold it.
Mm-hmm.
It
it'll cut off your circulation. So if somebody's bleeding and you need to cut off their circulation, do a tourniquet really, really tight.
Is that right? Depending on where the injury is.
Yeah, you can even do knee if it's lower leg. Tourniquet. So here's a side picture of the sciatic nerve. If you look here, this is your iliac crest on the top. Right here. This is the greater trochanter on the side. Right? Bursa. But yeah, sciatic nerve, huge. And then you have posterior connective tissue structures. Fun. So I'm just going to zoom here. Here's your gallia epineuritica. Runs down. There's a huge ligament that runs down your back. Ligamentum nuchae. Right? Keeps running down. Supraspinous ligament. Keeps running down. Right? Straight down. This is why they say that craniosacral therapy is a thing. Because not only do you have your fascia, but you're affecting the craniosacral fluid to kind of balance everything out. I love this. He's happy. I'm happy. We reached the summit. Goodbye.